Hey, we hooked up to my headphones or something. I was wondering why I couldn't hear you.
I thought I had unmuted myself and apparently I did not. So that was fun. Okay. All right, I hit record, so we're good. I'll go ahead and get started. I know you're busy. So I will share my screen.
I'm sorry that I missed that exam review guide. I'm so sorry. I think I've looked through the announcements so much I'm missing stuff.
I know it can take some, yeah, there's a lot that we post a lot of announcements. So yeah, no, I get it. There we go. All right, so I'm sharing my screen. Can you see the exam review guide?
Yes.
Okay, perfect. So I'm gonna start at the top. I do have some additional notes as well. All right, so I'm sorry, let me start over that. Exam 3 got a lot of chapters. So I wrote the chapters down. It's the concepts from weeks 6, 7, and 8. I moved, so I apologize. Everything is a little discombobulated behind me,
Oh,
but
that's okay.
so it's going to be chapters 5, 6, and 7, 11 through 19, and 27 and 28. But I will tell you if you follow your exam concepts guide, you are going to be good to go. Okay. So we'll just go through it. So again, week 6, 7, and 8. So, look at my recordings, look at all of the other instructor test reviews, the Kahoots. I promise you, it's gonna help you. It's gonna help you. Um, it's 50 questions, select all that apply, multiple choice, and your math, of course. You have 75 minutes. So, all right, so we'll just get right down to it. Let me get a little bit. It's like really big on my side, but like my notes, need to make my notes bigger. There we go. I could not see my note. All right, I made it a little too big. All right, come on down. There we go. All right. So when we look at doing a community assessment and evaluation, right, we talk about the dimensions of a community assessment. So the dimensions of place, of person, of people, of function. And so we have to look at all of that data. So when we're looking at people, we would access data sources from census. Remember, you can go to like your census reports. The tourist bureau, your civics groups, your churches, all of those things would have, the availability to access the dimensions of people. And so when we look at doing that community assessment, that is what that's primarily what we're doing, right? So first we need to go and we need to look at the population and what the needs of the population are, regarding whatever it is, whether it's education, whether it's other resources, but we're going to look at the population to see what's going on. We also, sorry, when I have like two screens up. So when we look at active versus passive partnerships, active participation, that's like your community leaders, your businesses, other organizations within the area. And so an active partnership would be like after school programs. You send your kids to an after school program. Those are they're usually less expensive than sending your kid to a regular daycare, right? Um, and so looking at businesses that would offer like the after school programs, low cost snacks. Maybe they can, make a deal and, like kind of give them a low cost option on snacks. so that the prices of those after school daycares or after school programs can stay low, right? Because if they have to go and they have to pay more money to get, the same snacks, right? That's going to increase the cost for the community to put their children in those programs. Um, your passive partnerships, that's like your recreation centers, your vaccination clinics. Um, those are a little bit more passive. Whereas they are still providing a resource to the community. It's not an active participation right away. Um, and then, of course, we do have what is called a windshield survey. And the windshield surveys, where, that's the one like the book describes, like you're literally driving around the community and you're looking at your windshield at what is in the community. And so biggest thing that the nurse needs to understand during that windshield survey is the boundaries. Where does the community start? Where does the community end? So that helps them to, develop that goal within that one size community. We look at evidence-based practice, evidence-based practice. I know you've heard that probably day one from nursing school, right? That represents that cultural change in practice. And so the first step is recognizing the current status of one's own practice, right? And believing that care is based on best evidence that will lead to improved client outcomes. So it's always about research. What is going on? What does current research say? And we always teach nursing students and nurses, right, to always have that questioning attitude, right? Even up to including, can we do this better? Is there a safer way? Is there a better way that we could do it? And it's all based on evidence. I asked once during a partnership meeting with some clinical sites. And, I asked about that, especially with new grads, because you guys are coming out with all this new, more, not that we're talking like current, textbook knowledge, but you're still getting lots of information in nursing school. And so, yes, like they do take, they have groups and stuff that are in, the hospitals, and they encourage you guys as new nurses to do the research to see if there's better ways to do things. So evidence-based practice is real. When we look at evidence-based, or I'm sorry, like I need to move forward down. Environmental risks. We look at environmental risk. We know that there is a ton of things out there. How do we apply the prevention levels, the primary, the secondary, the tertiary levels, occupational environmental concerns. So basically, and kind of falls into disaster management. So I'm just going to kind of skip down to disaster management for a sec. So we look at disaster management. These are natural or man-made disasters, right? So disasters can be things like tornadoes, they can be hurricanes, floods, or they could be pollution, warfare, fires, water supply contamination. We look at what is it called? Not biological warfare, like smallpox, anthrax, things like that. And so with Healthy People 2030, the objectives for disease mitigation focuses on preparing, alerting, and caring for disaster within a population. And so one objective focuses on increasing the proportion of crisis and emergency risk messages to protect the public. And so, what are some things that we can do within our communities to help prepare families? So emergency kits, that is key, right? Always have an emergency kit and an emergency plan. in the event of a fire, of a flood, of a natural disaster, right? What are things that the family will need in order to safely evacuate the house? Or if unable to leave the house, how do they, hunker down and, survive? So, rule of thumb is, have enough food for at least 3 days. Make sure you have plenty of extra water in the house too. Um, Make sure that there is like an emergency kit, where the emergency kit is, right? We are all famous for that, right? You get something together and you think you put it in a safe place and then you forget where you put it, right? So where's the emergency kit? And how to turn off utilities to the house, right? So where's the water shut off, right? So we avoid contaminated water getting into the house. If we have to turn off the electricity to the house, the gas, where are those, where are those shut offs, valves or switches, right? So like not here, but in my house in Virginia, right? In the garage, we had a gas shut off, right? You just flip the switch. It was like a light switch on the inside of the garage door. You just flipped off the switch. We had a water cut off in the garage as well. Not as easy to get to, but we could do it. So like, even if it's, having it on a piece of paper, like, here's the gas, here's the water, what do we do? How to flip the breaker on the breaker box to shut off the power. So those are important. And then making sure that they're going back and they're reevaluating what's in that kit, right? So, you know, you don't want the food to be expired or any of that kind of stuff. Um, and then, mass casualty drills, these are usually done at um, either a community or even more a large scale, effort. I talked about like, doing them in the hospitals, and that was actually a really fun experience to watch. When a federal emergency has been declared, the National Response Framework may provide specific needs to a community, especially if our community resources get overwhelmed, like our local community, right? So our fire, our EMS, police, our health department, our, whatever is local within that. Um, Other parts of disaster management, looking at patterns of outbreaks. What it, we talked about the different things that were reportable to the health department, right? So, say you have a salmonella outbreak or something along, right? We wanted, be able to identify those, assess and then educate. When we look at terrorism, for certain communicable disease like smallpox, we know that not everybody gets the smallpox vaccine, right? But if we were to have a case, say you're working in a hospital, right, that nurse manager is going to start being able, or is going to start getting the smallpox vaccine, giving it to the workers in the emergency room so that we could deal with that. um Other things like tertiary would be, after a natural disaster, helping them, helping to find housing, providing counseling, support, medical needs. So like if there's a tornado or a hurricane, right? We go out into the community and then we're, almost like the cleanup part, right? We're looking, how meeting those basic safety needs according to Maslow.
Professor Martinez.
Yes.
Why we're discussing prevention in like a disaster, so why we're thinking about it, like primary prevention would be to, is that prevent it? Like you'd want to prevent a disaster or maybe prep for it?
Prepping.
Yeah.
Yes. Yeah.
And then
Um, so yeah, so like what can we do to try to prevent it? So like think of I always think of the movie Twister. I know it sounds crazy, right? But one of the goals of hers was the early warning system, right? To kind of give them a little bit more time to, um, respond, like whether or not they had to evacuate, that kind of thing. So yeah.
And then
Um,
secondary, I'll need help with that too. Would that be identifying the disaster or crisis?
Secondary for, I was trying to see if there was something in the book that would give a good example. Um, yeah, it would be like the response, right? So like, how, getting, the emergency response plan would be your secondary in that situation, right? How do we get um what do we do? Because it's going to be a little bit different, right? Because if we can't prevent it, right, which is would be the primary, like we primary would be prevention and getting the plan together. And then secondary would be, you know, um, activating the plan, and then of course doing your assessing for damage, like assessing your patients. And then tertiary would be, you know finding them housing and all of that other stuff.
Okay, thank you.
Yep. Sorry. Yeah, because it's different with community health. Sometimes you have to think a little bit different, especially with a disaster, right? Because, there's only so much that we can do to prevent things, right? And so once, you can be as prepared as possible, but it doesn't always, right? It doesn't always happen to work that way. Um, with economic influences, um, the primary prevention for economics would be to advocate for healthcare financial aid legislation to address financial issues regarding access to care, or even like working with insurance companies to provide necessary coverage. And that had a lot to do with the Affordable Care Act. Um, or even, what about um, advocating for financial aid, right, for healthcare services for like families that are at risk or that can't afford health insurance, right? That would be another one that would be more of a primary prevention when we're looking at economics. Um, just because, even though the Affordable Care Act did try to make a huge shift so that everybody could get healthcare, we still know that there's plenty of people within the United States that don't have access to healthcare. So what are some financial, things that we can do to assist them? My computer. Um, Health information, this is your informatics. This is a lot of, gathering data, um, you know, and then what do we do with the data that we're learning that we have? So, is there a high rate of diabetes in the area, or high rate of hypertension, or what another disease um, process, violence, it could be anything. Um, and, that is, when we're looking at developing the programs, education, we're going to look at the population that the education is meant to be developed for, identify that issue, and then we're going to select a learning theory and then to choose the teaching strategy, right? And so we have different strategies. We have the cognitive, we have the affective, and then we have the psychomotor. So your cognitive, right, that is, your how you learn, your memory, memorizing. I have these all in my notes. Now I can't find my notes. memorizing, recalling information, that kind of thing. Whereas you're affective, that is your feelings towards it. So, how did they have a specific feeling toward, or sorry, yeah, like how do we change their attitude? Regarding what we're teaching them, right? So if we have a patient that has hypertension and doesn't believe that it's an issue, right? What can we do to provide that education so that they understand that it is an issue, it's going to affect their life, and that we need to have him make those changes. And then psychomotor is your skills, right? Being able to perform the skills. And we sometimes will have to do an assessment on them as well, because think of, I always think of elderly population, and this is probably out of, this, but sometimes they don't have the manual dexterity for certain things, right? So, drawing up insulin or even seeing the little lines on those insulin syringes, right? So we have to take all of those things into consideration. But again, in addition to determining what the learning plan is going to be, we are going to look at the population, and then we're going to develop our education program. And then, of course, with the education program, you want to make sure that we're providing the information in the correct language, right? With the correct information, that we're providing both, or we're meeting the needs of all learning styles. So we'll provide like, um, uh, pamphlets, flyers, videos, that kind of thing to kind of, address every one of those learning styles. Um, Government, the law and policy activism, liabilities of case managers. That's kind of the same just as we talked about for nurses, right? When we look to see if they are negligent, right? They have to have had a duty to provide reasonable care, that they had a breach occurred through an act or an omission to act, or the act or omission caused injury or damage to the clients. Case managers are really good. Many insurance companies utilize case managers, hospitals, right? Use case managers, especially with some of our underserved population, or even some of our chronic disease patients, like your hypertension, your diabetes, so for kids like with cerebral palsy and things like that. Um, big, the one of the fundamental skills of a care manager is that they have to have strong advocacy and negotiation skills, right? Because they are dealing with, just take one person that has diabetes, right? They may have a primary care physician, they may have an endocrinologist, they may have a nephrologist, they may have a podiatrist, uh, they may even have a cardiovascular doctor, right? So they're, working with groups, within this, these providers to provide care for one patient. And getting them appointments, and managing all of that. They also have to advocate for that patient to make sure that the patient is getting everything that they need. The nursing process is followed with case managers, just like it is with, us as floor nurses. And of course, we know that um, the patient, or the case management plan needs to be individualized to the specific patient, right? One of the potential challenges for case managers with resource allocation is the limited availability of healthcare providers. And so especially mental health providers, right? That's a huge issue right now within the United States, is finding those mental health providers. And it's across the board from pediatrics to geriatrics. Another thing too, when we look at case managers, so I'm a case manager, I'm not, but I'm a case manager in the hospital. I'm getting ready to discharge my patients are getting discharged home. What do I need to know from that nurse? Right. So the nurses that are on the units, they need to be able to provide the case managers with the appropriate information so that I, as a case manager, can make sure that when that patient is discharged home, they have everything they need. Right. So if I have a patient that has congestive heart failure or respiratory issues and they need to be discharged on oxygen, I need to know that so that I can make sure that there's oxygen available when that patient, right? That needs to probably be delivered prior to the patient being discharged home. Um, what else? If I have a patient with hypertension and they need to monitor their blood pressure daily, right? I need to know if, can the patient, because that's usually not going to be covered by, insurance, right? But can they afford to go get a blood pressure monitor, that kind of thing. So as case managers, that's part of their goal is, or part of their job is to make sure that the patient has the equipment and everything that they need when they get out or when they discharge home. Um, oh, I did that. Okay. When we look at violence and human abuse, and think this is probably one of the, worst parts of right of anything that we have to deal with is thinking of violence and human abuse. Um, Intimate partner violence and abuse, one of the big risk factors for homicide is a wife that reports that she's been physically abused prior, right? So if she's been physically abused by her partner, then she's at a greater risk for, intimate partner homicide. Um, Interpersonal violence is more likely with someone the victim knows, right? So whether it's, a current partner, a past partner. Um, Primary prevention is a community approach. And so what are some things that we can do within the community as primary prevention is a lot of education, right? So like we can educate communities about the different forms of violence, ways that they can get help and intervene, preschool programs like your Head Start programs for intellectual and social skills, family programs to teach parents how to deal with their children more effectively. I wish I had that when my kids were younger. Um, Nursing home visitation programs with families at risk. So think about this, we put our family members into long-term care facilities, right? And I'm a Jerry nurse. Jerry, I know it's weird, but Jerry and pediatrics, those were my two specialties. And Jerry, a lot of times they put their family members into the nursing home and never come to visit. Some families are extremely active and they're there very frequently, while others, if you see a family member once every other month or, sometimes never, right? It really just depends. And so who's really advocating for that family member? And then take into consideration your non-maleficence, your beneficence, your justice, right? Justice is treating everybody the same. With beneficence, we're looking at minimizing risks, right? Minimizing harm. And of course, non-maleficence is do no harm. Um, with infectious disease prevention and control. So your Healthy People 2030 immunization infectious disease areas of focus where your vaccine preventable infectious disease, your STDs, your pneumococcal infections, your healthcare associated infections. So, right, we already know that vaccines are primary prevention, right? That's how we control our, it's one way that we can control our communicable diseases. You have kids, right? No. So kids, they spend the first 2 years in the doctor's office, it seems, right? Because they go in for their newborn check, their 2 week check, their 1 month check, then 2 month, then 4 month, then 6 months. then 9, 12, 15, 18, 2. And then after 2, it's yearly. So you figure that's 7 visits in 1 year, not to mention if they get an ear infection or, something else that's going on with them. So, and usually at each one of those visits, they are going to get immunizations. And so, we do have the program here in the United States that, kids are supposed to get vaccinated prior to them going to school with the No Shots New School legislation. Um, your minority groups, your ethnic groups, those are at risk. Those are the ones that are primarily at risk for incomplete immunizations. Um, Research shows too that adolescents have lower rates of coverage than children or adults because they don't have frequent access to preventive care. And then we look at, biologic weapons like your smallpox that we talked about, right? So if I was working, and we had a smallpox, we'd be vaccinated. Um, they don't vaccinate the public against smallpox. I think they used to, not my generation, probably, I think it was my mom's generation. Um,
Isn't
but
that the one
then,
that leaves the scar on the arm?
mhm,
Yeah.
yeah, and they stopped. I forget why, not gonna lie. But I also know that the immune properties of the smallpox vaccine also wear off. So they would probably need to get another one should they be exposed. So that's the only real primary. However, you can still get the immunization if you are exposed to smallpox. So that is something that, would also help. But some of the other things with, you know, um, even going into the HIV infection, TB, and STDs, when we look at our prevention levels, we know that vaccines are primary prevention. But we look at, STD testing for pregnant women, right? Some of those STDs can cross the placenta and cause risk to the fetus. Um, the secondary prevention for tuberculosis, that's your PPD, and your chest x-ray or the TB testing and the chest x-ray. Again, primary is prevention, right? So limiting exposure. We don't use the tuberculosis vaccine in the United States. Other countries do. Um, we generally don't have a huge number of tuberculosis than we do in certain populations, but not in like general population. Um, what else? Um, and then, other things as far as infectious disease prevention and control or even surveillance, is, teaching food safety. How do we store our food? How do we prepare our food, to prevent outbreaks like salmonella, um, as well. Um, with surveillance outbreaks, observation and surveillance is the process of ongoing systematic collection, analysis, interpretation, and dissemination of health data to monitor disease trends. So when we look at the pattern of observation, is assessing the public health status, right? Identifying trends of disease patterns, set priorities, and then develop programs for rapid response. And the goal is to reduce any morbidity and mortality by preventing or controlling the spread of disease. Um, and so we have active and we have passive surveillance. A passive system relies on healthcare providers to report existing cases. So that's one of the reasons why they have those reportable illnesses. Your STDs, your diphtheria, your measles, your mumps, salmonella, all of those things. We have those, they report the existing cases to the health department, and that is a passive way. In the active system, the health department is actually going to search for cases by contacting providers. Like, hey, Dr. Jones, have you guys had any cases of blah, 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 that kind of thing. So that's more of an active, whereas the passive, we're just waiting for the information to be provided to us. Let's see, when we're looking at managing quality and safety, when we're looking to see if a program has enough resources, we're looking at sustainability. When developing a quality improvement program to improve client satisfaction, we are going to target the staff, right? So, like I said, I worked in long-term care. And there's been a huge shift, even within hospitals, from quality of care, or from quantity of care to quality of care, right? So you can spend 12 hours in one patient's room providing all that care, but if that patient is not satisfied with the care that you provided, right, that's a huge issue. So there's been a huge shift. So a lot of it is, how do we work with the staff to improve client satisfaction? So what are some customer service techniques that we can provide to them? Let's see, what else? Your tertiary prevention would focus on outcomes of a quality improvement project, to decrease the incidence of a disease or improve quality of life. Um, so, that's tracking the community incidences of complications from vaccine preventable diseases. Um, a primary quality prevention is education on vaccines. Tertiary are carried out when evaluation indicates need for improvement. So, for example, examining a response to a fire, it has already occurred, is an example. So, you know, um, what I'm trying to figure out. I'm just trying to put it in my head. So, you have your primary, of course, is prevention. Your secondary is going to be your implementation. So say we had a fire, and we're going to go back and we're going to evaluate the response. Okay, it's kind of like, where do you work now?
I'm a community health worker for pediatric mental health.
Okay, so say you had a fire at work. Okay, knock on wood, right? But or an incident at work. Well, you don't even have to use fire. You had an incident at work. All right. And it's kind of like when we go back and we do an evaluation of like, how did it go? Right. So, maybe you had a patient escape or run away from the facility. Okay. I've seen pediatrics, like patients dart out the front door. So, but you have a system in place, right? So you start here and you go here and you do here. So this is like the after action, right? So a tertiary would be like, okay, so let's sit back and let's look back and say, what happened? We pulled the fire alarm, we did this part, we did that part. Is there anything else that could be done? Is there anything we need to do differently? Right. So that's kind of what, when we're looking at the quality, or the prevention with quality improvement, that's what we're looking. It's like an evaluation of, is it working or is it not working, and then what can we do differently to make it better. When evaluating the program itself for quality improvement, the first phase is the structure phase. And that's where The nurse determines if the philosophies and the objectives align with job descriptions and organizational standards, right? So having a good job description allows you to know exactly what you're supposed to do, right? If you just, if you just applied for a job and, just was handed a title without a job description, would you really know what to do? Not really, right? So it's kind of looking at those job descriptions, making sure that everybody is in alignment with what they're supposed to be doing. And that includes even when we're looking at delegation, right? So what are some things that we could delegate as an RN? What are some things you could delegate to a LPN, to a CNA, to a home health aide, right? That would be all be included in a job description, like what their scope of practice in nursing terms would be. Um, ethics in public and community health, touched on this a little bit. The ethical principle of beneficence is minimizing risk while maximizing the benefit. So like, let's say that you had, a patient that wanted to go AMA and you, instead of just educating the patient on why they should stay, you decide to barricade them in their room, okay, which we can't do. Not only is that false imprisonment, but that's also a violation of our beneficence, right? Um, Justice, right? We treat everybody the same regardless. Utilitarianism is the ethical theory that outcome is key, so the action must justify the means. Deontology is a theory that adheres to moral rules or duty rather than consequences. Distributive justice looks at whether the action will create a burden, can't talk. And then feminist ethics advocates for economic, political, and social equity, and rejects the abstract rules and principles. You can check on my notes all here. And then, of course, cultural influences. We know that this is a big part of our healthcare. So like working with immigrants, things that need to be assessed or considered. We need to know their financial constraints, any language barriers, um, any differences in social, religious, and cultural backgrounds, traditional practice, lack of healthcare provider knowledge of the needs of the immigrants can be a factor. So when we're looking at finding a healthcare provider for certain, depending on where they are coming from, so whether they're Hispanic or another type, another group of immigrants, seeing if we can find a provider that, is used to working with immigrants, right? Like maybe they have a Hispanic background themselves, and they understand that culture a little bit better than maybe some of the other cultures, right? But that definitely is, especially with financial and language barriers, it's always better, right? If we have somebody that has the same language. Family conflict can also develop from the changes in the environment and the challenges of adjusting to a new culture. Um, or refugees, think about what they've been through. They may have left their homes due to a disaster or under, horrific circumstances. They've experienced traumas, in some cases, even tortured. And so the priority for us when planning care for refugees is access to care or access to therapy as well. Um, and so they need to have access to therapeutic care. And that's one of the biggest goals with the refugees, right? We always talk about providing holistic care, right? But they, that especially are going to need that therapeutic care very quickly. We look at Native Americans. Native Americans are often past oriented. They're not often concerned about the future. And so we try to avoid future oriented things with Native Americans. Um, they also avoid unnecessary eye contact. So that's something when we're communicating with a Native American, right? We don't have to sit there and stare at them in their eyes, right? You be careful with your eye contact. With Hispanics, we want to avoid negative expressions. They do consider that to be impolite. They like the banter, right? They like that free communication. Um, what else? Oh, and then of course the Hispanics, they do expect direct eye contact and physical contact. They're a very affectionate population. Um, Other parts of culture, right? When we're working with certain populations, even, thinking about some of our older adults that live in rural communities, ensuring that they have transportation to, their healthcare appointments, because that could be a significant impact on them as well. Great. Any questions? It's all yours now.
Uh, not on the material.
Okay.
I don't know. If you, I emailed back about us
Oh,
meeting.
let me,
Yeah, I didn't know if you wanted to record that.
no. All right, let me stop my recording.